that, make sure to be looking for your newsletter. That should be, oh, hang on. Oh, sorry for the pause, everybody. I was just making sure we were actually live. So we are. Anyway, be looking for your December newsletter. There will be some upcoming classes in there and our holiday party. So we can get together in person, but we're going to do a virtual version, which is really exciting. So make sure to sign up for that on our website. Also, after the class, you will receive an email and it will have a link to this class to watch back, as well as a survey on how you like the WebEx format. And it will have information about the class that was shared today. So those are all my little tidbits before we get started. If you have questions, please feel free to ask those underneath the presentation. There is a form that says ask a question to the presenter. Just put your question in there and we will get that asked as we go along here. So today we have our speaker, Dr. Amar Rawal. And he is with the SIH Medical Group. He is a urologist, and we are so excited to have him with us today. And I will hand this over to him and let him get started.
Great. I hope everyone can hear me okay. Good afternoon. I'm going to just put my opening presentation screen up. Can you tell me if you can see it?
Yes, looks good.
Very good. Okay. So thank you for having me. It's my first time doing this, so please forgive any mishaps while I'm presenting. I am one of the urologists with SIH. I primarily practice at Heron, and I've been at SIH now for just over 12 months. I primarily specialize in men's sexual health, men's pelvic floor disorders. I also see women for female pelvic floor disorders, as well as other stuff that most urologists would do, prostate issues, kidney stones, cancer. But my primary interest, my training is focused around pelvic floor disorders. So I will expand on urinary incontinence. My first question, why would anyone want to talk about this? I don't get paid for it. I trained as a urologist to train this, to treat this. This is why I decided to do it. And I firmly believe that if I can educate our community to make better choices, be more mindful about what they do, the patients that I see in clinic will have a better chance of complying with my treatments, my recommendations, and they'll be empowered to understand and actually follow through with what I tell them for a better outcome. And if it's not something where I can help them overcome it myself, I will help them seek the appropriate person to overcome their problems. I have no disclosures, that's my final statement, and I'd like to move on to actually talking about urinary incontinence itself. So it's very common. I find that a lot of my patients, when I speak to them about urinary incontinence or when they bring it to my attention, shockingly to me, they say, I've had it for years. I've had it for 10, 15, 20 years, or as long as I can remember. And the only reason they come to me is because their primary care physician happened to find it and recommended that they see a specialist. Or the other reason would be that it has gotten so bad that they cannot sleep through the night, or they're too embarrassed, or they get depressed from the extent of it. It's defined as the involuntary loss of urine. And when I say involuntary loss of urine, it's at an inappropriate time without the patient or the individual feeling it's appropriate to eliminate or empty their bladder. Other types of incontinence would be fecal incontinence. And that would fall in the realm of colorectal surgery, not urinary. It's not unusual to find people who have an element of both. There are various reasons which we'll go over, but it is estimated that, according to the last national study that was done in the early 2000s, about 13 million adults in the United States with urinary incontinence of some form. Women are more affected than men, somewhere between a ratio of 2 women per man. But this difference starts to even out with increasing age because men end up having various issues once they reach, pardon me, can you still see my screen? How's that? Can you see my screen there? All right. So like I said, most of the differences even out with age because men start to develop prostate issues, and that has a greater role to play with urinary incontinence. What's interesting is 1 in 4 women experience urinary incontinence after age 18, which seems like an awfully young age for a girl to start talking about urinary incontinence, but a lot of it begins with pregnancy and the growing issue of smoking and obesity as well as diabetes. How can I get out of this? All right. So why are we even talking about it? It's socially embarrassing. No one wants to wet their underwear. You've grown up dry, and then suddenly you realize you cannot control your urine. There's a sense of lack of control. There's a personal decline in quality of life. I've had patients tell me things like, I can't even leave the house. And that leads to depression. And that leads to patients being put on antidepressants. But that's not really addressing the issue. The issue is, why did they end up being depressed? Why are they at home? And we live in such a fast-paced environment in healthcare where we think of every issue as something we can throw a medication at, something we can get a pill thrown at so that we fix the symptom. But usually it's not the symptom that's the underlying problem. Is, well, how did we get to where we are? And often I find that if you really dig deep behind depression, there is a strong underlying reason behind it, which sometimes gets overlooked in the stress of the healthcare environment with restricted time. It is expensive. The cost of incontinence wear, now I wasn't aware of that, I had to look this up. It can cost anywhere from $200 to $1,200 per year for an individual with incontinence to keep themselves from wetting their clothes. Now, normal insurance companies cover that. I know that because we have numerous patients who say that they have to buy supplies out of pocket from Walgreens. The estimated costs to nursing homes, where obviously the majority of the elderly population and the medical comorbidities are, is about $5 billion a year. So it is a burdensome problem. The types. Now, this, strictly speaking, is not something that would really be something of interest for patients, but it's useful to know because it tells me what category you're in. Is it urge urinary incontinence? Is it stress urinary incontinence? Is it mixed urinary incontinence? These would be the primary 3. Constant urinary incontinence is rare, and it's usually not something I would see in a grown-up adult urology practice. This tends to be more pediatric. But male and female causes are distinct, they overlap, and in some cases they are specific to the gender based on anatomy. Urge urinary incontinence. Typically, if this looks like you probably have urge incontinence. It's my average patient would say, usually a female, average patient would say, I cannot make it to the restroom in time. My bladder has a mind of its own. It starts to discharge by itself. And I'm already going by the time I make it to the bathroom. In some cases, the minute their brain senses the bladder is full, they have barely seconds to act to make it to the restroom. Stress urinary incontinence. This is something where it's more a situation where they know that they have a weak pelvic floor. They're aware of it. They've witnessed it and felt it over several years. As soon as they move, they feel it down their leg. They leak when they laugh. They leak when they sneeze, when they cough, and they feel like, I've heard some men describe it like a faucet when I lift something. Another guy that I had recently said that it was when every time he pushed the lawnmower, he would feel his depend filling up. It's one of those things which, in my opinion, is very unpleasant. If you imagine you being dry, your health deteriorating to the point where you have no control over urine, which leads to a smell, which leads to you wetting your clothes and needing to change them. In some cases, which leads to you losing your independence and your ability to leave the home. It has many detrimental effects which accumulate. Risk factors, female risk factors and male risk factors, like I said, they overlap, but I'm just going to go over it in terms of women and men separately for the sake of making things a bit more clear. The first four: active urinary infections, obesity, smoking, and diet. Now, I'm shocked by how many people walk around with a urinary infection which hasn't actually been tested for. And I would probably see a handful of patients every year where the urinary infection hasn't been outruled. If you can treat that, your urinary incontinence will more often than not go away. Obesity, smoking, and diet. Being overweight. Now, if I refer to this picture on the right side, being overweight, you're putting all this excess pressure from your abdominal wall to sit on the bladder. And that bladder has to deal with basically a roof that's collapsing. If you imagine a roof that's collapsing and a bladder that keeps filling, the only direction it's going to give way is down. Same thing happens with smoking, where it's your lungs that are constantly being filled with an irritant, the smoke. The smoke irritates your lungs. You're living in a state of high pressure lungs from coughing all the time, the smoker's cough that people speak about. That puts pressure on the abdominal wall as well, and the roof of the bladder has to collapse. If it does, the only direction to release the urine is down. Diet. This is again one of those things that ties in with lifestyle obesity. One thing I've noticed is the high consumption of caffeine in I guess general Western society. I was shocked to see how many people drink as much as 3, 4, 5 pots of coffee a day, plus a bit of Mountain Dew, plus a bit of tea, sweet tea. These are all potent diuretics. Diuretics meaning things that provoke your kidneys to crank out urine. Even though your kidney doesn't want to, it stops your kidney from being efficient at its job. And that bladder is filling. No matter how often you empty it, that bladder is working overtime. In my experience of having done this for however many years, every time I've recommended switching to decaffeinated beverages, most people have told me I have improved remarkably. They may not have reached the point at which they want to be, but they feel that they have improved. And the best thing about it is I didn't give them a pill. I didn't recommend any physical therapy. I didn't recommend anything that they felt will cost them money or cost them time. All they needed to do is make a lifestyle change. And that's what the first 4 items is so easy to overcome, are so easy to overcome. Now, specific to women, the hysterectomy, the growing number of women who undergo hysterectomy eventually end up with a pelvic floor disorder. Why? Because the uterus is associated with the uterus is very closely associated with your pelvic floor musculature. And in order to remove the uterus up here, you're damaging, or inadvertently, the surgeon would have to sacrifice the support system and the support structures for these three organs. Everything is held up against the bony area up in the sacrum, and when you cut the uterus out, that support system, the hammock mechanism, starts to cave in on itself, and then you start developing prolapse and weakness of the bladder. Multiple vaginal births does the same thing, where all these tissues get stretched and contract. They stretch and contract over time. Those tissues are no longer as strong or muscular as they used to be, and it doesn't take much force for a cough or a sneeze to overcome tissue that is weak. Menopause has the same effect. When women are premenopausal, the estrogen makes the tissue strong and elastic. When estrogen influence goes away, the urethra, the urinary tube, and the vaginal tissues all start to shrink, and they become less elastic, and there's loss of control as a result, because there is no longer that support, the elasticity, the collagen that was once there. Referring to surgery here, it's mostly the hysterectomy. That's primarily what I was getting at. Stroke, neurological, and spinal cord injuries. When we were children, when we were newborns, our bladder control was governed at this level. Our control of urinary elimination, how we peed, there was no conscious awareness of it. We had no clue when our bladder was full. We had no clue when it was appropriate to urinate. That is a learned behavior that as you grow up, your brain trains itself to do. When people suffer a stroke, when people suffer a neurological injury, when people suffer a spinal cord injury, that communication is disrupted, and you go back to having what's called spinal voiding, where the bladder fills and starts to discharge spontaneously. However, this isn't something that is reversible. This ends up being something, in many cases, that's permanent, or at the very least has some lasting effect if it doesn't end up being permanent. In medications, I frequently have found patients who take diuretics like Lasix, HCTZ, amiloride, they tend to leak urine more frequently because they have the existing problem that we mentioned of a weak bladder, they have menopause, or they smoke. And then you exacerbate that with a heavy coffee intake, and they take Lasix, their kidneys are just pumping out urine. And the urinary bladder fills up so quickly that they are just unable to manage the repeated trips to the restroom. You compound something like a bad hip or a bad knee to that, there is no way these people who will be sitting watching TV can be able to make it to the restroom in time. So if you look at what causes urinary incontinence, and you look at how everyone is inevitably deteriorating, and we make these choices that make something worse, it's very easy to just tip the balance and fall into someone who has regular urinary incontinence that initially you ignore, and then it gets worse as women get menopause, as smoking takes its toll, as you gain a bit of weight. Those things add up and tip the balance. Now, in men, it's very similar. It's active urinary infection. I've got the anatomy for reference here. It's a little bit blurry, but you get urinary infection, smoking, obesity, diet. These are modifiable things. These are changeable things. These are treatable things. But in men, when the prostate comes into play in their mid-50s to early 60s, some of them end up having prostate surgery. Some of them end up having prostate enlargement that is yet to be addressed. They start developing what's called overflow incontinence from prostate enlargement, where the bladder is really full. It's living in a chronic state of being full, and the prostate acts as basically like a choke. It chokes on the bladder and it stops it from emptying. But then as this gets worse over time, the bladder starts to get more muscular. It feels that it has to grow stronger to overcome the resistance. The resistance from the prostate, the only way it overcomes it is if it gets bigger and thicker and starts to push with more force. However, a big, thick, strong bladder is not good. It eventually starts to become irritable. And then it starts to discharge at its own will. And this is what's called overflow incontinence, where it has to push the urine through the prostate. In the long term, it'll start doing it on its own, causing urinary incontinence in men. Prostate surgery, frequently, if you see where the prostate is located, it's below the bladder, and it's just above this muscle here, this thin muscle, the pelvic floor, which women have too. This is the muscle which can often get damaged during prostate surgery, which is it's the dreaded complication of any prostate surgeon, that if you damage the muscle, the patient ends up having a severe degree of incontinence. It's miserable for them. And when that happens, they end up having stress urinary incontinence, where they do a little bit of a lift, a little bit of a cough or a sneeze, and that level of resistance is gone. The muscle mechanism that was once there is gone, and it's a free passage down the urethra through the penis. In terms of treatments, I always try conservative treatments first. I do lifestyle changes, I do weight loss, caffeine restriction, alcohol limitation, stop smoking, and if I feel that it's appropriate, I would refer them to a pelvic floor physical therapist. I have found a good physical therapist is worth their weight in gold. If they know what they're doing, they know how to work with the patient likes them, they're someone who is committed to their role, is something that is tremendously helpful, and thankfully we have that available to us. I find that having someone to encourage with smoking cessation therapy, having someone with nutrition available to us, these are all extremely useful tools to get the patient to understand and address individual parts of their lifestyle, which they otherwise just get told about. Go lose some weight, stop smoking, stop your alcohol, cut your caffeine. It's much more difficult to be able to make those changes without some form of a guidance, a template, an expert to direct you. And this is crucial. I find that if you have the team, you're much more likely to succeed as a patient and be satisfied with durable changes. To emphasize, pelvic floor physical therapy is something that is a long-term treatment for stress incontinence. It is not for urge incontinence. And there are many programs that I've seen where patients talk about doing Kegels because they watched it online, or there are these gadgets that help them strengthen their pelvic floor. While they may be useful, I don't think they are what I would recommend, because I simply don't know enough about them to comment on their efficacy. I feel that you need guidance. You do need someone to tell you whether you're doing a good job and you're doing it right. Despite the fact that you may think you may be doing a great job, you might not be exercising the muscles appropriately. Advanced treatments. So the treatments then start to differ based on stress or urge urinary incontinence. Bladder Botox injections and sacral nerve stimulation. There's always the joke whenever I'm injecting someone with bladder Botox, where someone will come up to me and say, "Could you save some of that Botox for me?" It is very much a different type of Botox. It's something that we inject in the bladder, no cuts are made, and we do it through the urinary opening in about 30 minutes. It's a series of small injections that we inject into the bladder muscle to diminish that overactivity. It soothes the bladder from being in a chronic state of irritation. And this is something I do, and I find it's tremendously helpful for several people, especially those who have spinal cord injury. because the spinal cord injury patients are the ones who are already familiar with managing their bladder with catheters and so on. And sometimes with Botox, you may have to catheterize yourself. So the people who are somewhat savvy, for lack of a choice of better words for it, savvy with managing their bladder with a catheter, they do very well with bladder Botox. Sacral nerve stimulation. I personally don't do this. This is done at Carbondale with one of my colleagues. Sacral nerve stimulation requires the placement of 3 or 4 electrodes, tiny electrodes, which carry current through your buttock towards the sacrum, or the bony area of your spine down below near the tailbone. And they stimulate the nerves in that region to regulate how they contract. In theory, the purpose of it, and no one actually knows how it works. It's somewhat of a mystery, but in theory, it's supposed to be a pacemaker for the nerves down in the bladder. If we can stimulate the nerves at a regular interval, it'll stop the bladder from discharging spontaneously and in undesirable settings. Like I said, both of these would be for urgent incontinence. Both of these require a procedure. And I found for the right patient, these are tremendously helpful. Advanced treatment for stress incontinence. The diagram on the right is actually the artificial sphincter, which is one of the things that I do in urology down here in Southern Illinois. But the first 3, pessary urethral inserts, these 2 are for women. They involve obstruction. You're obstructing the urethra from leaking urine. The pessary involves placing a round disc-like device into the vagina, and it kinks the urethra at the front. It's typically done by a gynecologist, and they usually have to be changed at monthly or so intervals for reduced rates of infection. They are very good for people or patients who do not desire anything like a sling, because the sling is the natural next move for people with stress urinary incontinence. The sling involves an operation in the vagina to place a synthetic mesh which supports the urethra. The urethra lives just in front of the vagina, and when you put this sling on, it acts like a hammock to stop the urethra from gaping open with little small increases in pressure during coughing, sneezing, and lifting. The artificial sphincter. Now, this is my baby. I actually love this device, and this is for men, specifically designed for men. It has been done in women. And if you look at it, where's my mouse? Here we go. So there is this tubing, and this is the tubing that goes around the urethra. The man's urethra, this will go in the perineum, otherwise casually known as the taint. We will place this in the perineum, and it wraps around the urethra. Right now, you can see, if you can visualize this small gap, the urethra will go through that. We put that in. There is the little regulating button device that sits in the scrotum up here. And this is what sits in the abdomen. And this is a pressurized balloon. When the patient presses the button here, what happens is this cuff deflates and allows urine to flow right through the channel. Over 60 seconds to 3 minutes, that pressurized balloon starts to send fluid back slowly, drip by drip, into the cuff, and that will re-inflate and re-obstruct the urethra. So it's a pressure-regulated timed balloon, otherwise known as the artificial urinary sphincter. I love this device, again, for the right patient. And these would be typically men who've had a prostatectomy. I think they have changed lives without exaggerating how I feel about them. I've had some great patients who were made miserable following a prostatectomy. The prostatectomy was inevitable, it was needed, but it's something that is very hard for men to accept. You know, I've had a patient who was a professional powerlifter for the state of Kentucky. You can imagine a powerlifter having had a prostatectomy when he lifted his weights at his kind of pace, and his hobby was making him miserable. And when we placed this device, he was absolutely delighted because it managed to allow him to go back to doing what he was doing. I don't think this device will keep the average powerlifter dry because it does have a pressure limit, but it improved him from where he was, and he was able to go back to doing most of what he liked. So that's basically the repertoire of things available to both men and women about in the realm of urinary incontinence and treatments. I'm very passionate about treating this condition because I feel that when it's not given the attention that it deserves, it tends to get put down the list of things to worry about. We've got much bigger things to worry about. We've got, right now especially, we've got other medical conditions that are more direct and visible threats to us that we forget to see or forget to address, problems that seem to be just smoldering in the background. And I'm here to help with those, and I'm here to help you find the appropriate people if I'm not the right one for the job. I think that's all I have.
All right. Well, that was wonderful. I learned so much. I guess I didn't really know very much about the subject. If you want to stop sharing your screen, and then I've got some questions for you.
Very good.
So, one of our first questions is what kind of exercises might be beneficial that they could start doing at home, or do you have any suggestions?
So, having spoken to physical therapists about what they recommend, what they usually say is, imagine you're in an elevator, and this is mostly for men, and there's a very good-looking girl right next to you, and you really need to fart. What would you do? And the first thing they would say is try and hold a pee, try and hold a poo. Hold the pee for a minimum of 30 seconds. If you can hold it, and I always tell people while you're listening to me, try doing it now. Try and hold a pee for 30 seconds. Try and hold a poo for 30 seconds. It's actually quite hard to do. You can feel the ache in your pelvic floor. And that's what we're trying to get to, is you want to strengthen that muscle to bulk up. So as a starting reference, try and hold a pee, try and hold a poo, do it for 30 seconds, do it 4 or 5 times a day or until the muscle aches. And you will notice that the muscle strengthens and you're able to control urine better.
Awesome. So to kind of go off of that question, to get to physical therapy or to get more exercises, would they need to first see you as a specialist to be referred, or kind of how do they go about getting that kind of help? Or yeah, does that kind of make sense?
Okay. The typical route to getting physical therapy or getting seen by me would be through a primary, because that's usually the most informative way to get me what I want. They'll give me your medical history, they'll give me your medical records, your surgical history, all the things that frequently people forget or don't have on them. Your primary will be able to send me very quickly and easily, and I will have a plan as soon as you leave the office.
Awesome.
Physical therapy, there is usually, to my knowledge, there is no direct route unless someone refers you. I don't think there is any restriction on a primary care being able to refer you directly.
Awesome. All right, great. Next question is, this person has an urgency to go. Usually when she goes to every store, she has to visit the restroom. Is that pretty normal, or is that something to kind of be concerned about?
It's hard for me to say based on purely urgency. Now, urgency means I need to go as soon as I know that I need to go. right? As opposed to someone who's on a road trip that knows they need to go, but they can probably hold out till the next exit. They don't have to pull the car over. So that's urgency. How debilitating is the urgency? Usually what I tell people is, if it's something that's so debilitating that you leak, or it's so debilitating that you have to look for the nearest restroom everywhere you go, you should probably get evaluated by a physician just to make sure that there aren't things that we can easily tweak in your medications. You know, I've had something, when I remember during my time when I was a resident, we used to have people that were taking Lasix, which is a potent diuretic, at night because they didn't know. So if you take Lasix, which is going to make your kidneys go nuts with producing urine, you take it at 8, 9 p.m., you're asking for the whole night being awake. But they didn't know. They've been doing it for years. They didn't know what Lasix did. So have someone review your medications. Have someone review your diet, your lifestyle. Have someone review your medical and surgical history to see, are there things that we can shift, move, adjust to improve it for you. And of course, if there is nothing that is jumping out at us, the next thing we have is testing in the form of urodynamics. Now, urodynamics is a special test where we put a catheter into the bladder while they are in clinic with us and awake. It involves filling the bladder up, and it's a simulation. You're simulating, what does this lady or gentleman's bladder do when they're filling their bladder up? Usually what we're looking for is, do you have a good capacity? A low capacity bladder is going to cause you to leak urine. And there are many causes for a low capacity bladder. Does this person have good sensation? If you have poor sensation, you won't know when you're leaking urine. And then what you make people do, if indicated, is you get them to cough. You get them to do maneuvers like coughing. You get them involved in a conversation. Do they leak with abdominal pressure? This gives us a clue as to where the weakness lies. Is it a weakness of the bladder? Is it a weakness of the urinary control mechanism? Is it a bit of both? You know, you can have an element of both. So there are a lot of finer things that someone who does it regularly can piece together to come up with a plan.
Awesome. All right. Next, this question is, I have a sudden urgency and when I cough, it pours. What can be done for this? I think you kind of talked on this, but if you wanted to go a little deeper on that.
So sudden urgency, so what I would describe, just from what you're describing, from whoever sent that message, it's you have what I would call mixed incontinence. You've got urgency, but then when your bladder is full, and a little bit of abdominal pressure will make you lose control. Mixed incontinence is down to multiple things. It could be an element of overactivity. Is your bladder in general overactive? And that tends to increase in incidence with age. Do you have stress incontinence where the pelvic floor is weak? Typically, that would be after a situation where a lady has had a hysterectomy or a male has had a prostatectomy. Very hard to evaluate without actually speaking to you, getting these fine details, taking a surgical, medical, and background history. I'm not saying that we always have the answer for you at the first visit, but I definitely think that if you work your way up in the ladder of management, we'll eventually get to a good, solid plan that is usually leaving the patient in a better place than they once were.
Great. And kind of our last question is, during sleep, I dream that I'm on the toilet urinating, but I'm still in bed. What can be done? Why does this happen? Is kind of the question.
Well, if you were anything like me, you wouldn't sleep. But yes, I think, I personally, it's unusual you mentioned something, or they mentioned something like this. I had a nurse talk to me about this just the other day. So I couldn't tell you why you have what you have. What the definition of what you're describing is, if you lose control, is called nocturnal uresis. The official term for it is nocturnal uresis, where you lose control of urine during sleep. There are multiple reasons for nocturnal enuresis, and as far as I'm concerned, it's not related to your dream. I wonder if your dream is related to having a full bladder, but that's me speculating, right? It's not your dream that triggered you to lose control. It's your full bladder that led you to dream a certain way, because your brain is geared to think that your bladder is full, therefore you should eliminate your bladder. Enuresis, multiple reasons for it. In the younger population, it's just immaturity, and they usually grow out of it by 18 at the latest, maybe 21. I'm no pediatric urologist to be able to quote you literature on it, but it's in and around that age where you expect the vast majority of people to have outgrown it. The other thing that influences how you fill your bladder up at night is your nighttime fluid intake. I am surprised at how many people are chugging fluids right the way through the night. You know, if you have a six-pack of beer right the way until bed, you will most certainly fill your bladder up quickly and wake up multiple times at night. If you're going to drink a lot of fluid before you sleep, same thing. Overall, you need to adjust. You need to be mindful of what you do before bed, right? Being mindful of what you're doing requires effort, because a lot of what we do is automated. Every day, the things you do is automatic. It's very seldom you drive to work, it's automatic. You frequently end up doing things that you're not having to think about. Just like that, the things you do at night are automated, and I encourage people, keep a diary. When you come and see me with a problem like this, have a diary and tell me, when did you leak? Was it related to how much fluid you had that day? Try and give me an estimate of how much you drank and what time. Does it relate to caffeine intake? Does it relate to alcohol intake? And surprisingly, when you quantify things and give people an actual numerical way to assess what's going on with their bodies, and you tell them your goal is to cut that by half, it's successful. It's when things are more abstract and subjective, it's very hard to make people change. It's like saying, cut your caffeine. What do you mean, cut my caffeine? I don't think I'm going to be able to go without coffee because I'll get a headache, right? So I say, why don't you cut your coffee instead of 4, drink 2? Why don't you switch to decaf 3 out of 6 cups you drink? And then they have a goal to work towards. Instead of saying something that's very broad and unhelpful, I just think giving them numbers works. And at night, have numbers. How much do I drink before bed? How soon before bed? Can you stop drinking all fluids 3 hours before lights out? And this is the term I use. I ask people, when do you go to bed? They say 9 o'clock. But when do you actually fall asleep? Oh, around 11:30. So you want, because they watch TV. So I'll say lights out is when you actually fall asleep. If it's 11:30, do not drink any fluid 3 hours before you know you're supposed to go to sleep. See how that works out. Interestingly, as a side note that I've noticed amongst some of my older patients, having really bad leg swelling, especially from poor circulation. And this is something that I suspect isn't very much talked about or even thought about. When you have a lot of swelling in your ankles, when you have a lot of swelling in your feet, most people tell me it was fine when I woke up, but it then steadily built up during the course of the day. And they're the same people who wake up multiple times at night. Why is that? It's because during the day, the fluid sits in your feet. The fluid doesn't move. It's static. It's not in your circulation. It's in your tissues. When you lay down, the effect of gravity is gone, and the fluid starts to get back into your circulation. When it starts to get back into your circulation, it gets processed by your kidney, and it makes its way into the bladder. What I tell most people with ankle swelling, regular feet swelling, raise your feet up every evening. Do it for about 1 hour and raise it up to the level of your chest so that you've got gravity draining that fluid down. And what will happen is you'll start peeing most of that volume from your ankles before you actually sleep. And that will probably give you a more restful night's sleep. And more often than not, patients have noticed a difference, or even compression stockings. When you use compression stockings, you're preventing that buildup of fluid from escaping at night. And it escapes at night because the factor of gravity is gone. When gravity is in, your ankles retain that fluid. When gravity is excluded, when you lay flat, that fluid starts to make its way back.
Awesome. Great answer. So I kind of had two questions come in. They're very similar, and it's about medications. So how effective are the overactive medications, and what are some pros and cons of using them? And are there any long-term kind of effects of using a medication for this? Their examples of medication were, and I'm probably going to butcher these, Versicare and Myrbetriq.
Myrbetriq, okay.
Okay, there you go.
Sure, no problem. No. So Versicare and Myrbetriq, or Myrbetriq. The overactive bladder medications are, for the most part, very few people have side effects. And they come in two different classes. They have anticholinergic and beta agonist. And what typically, the Myrbetriq is the newer one. That's the beta medication. I save those for patients who have failed the anticholinergic, because frequently insurance companies won't cover the cost of Myrbetriq first up. They need you to fail an anticholinergic because, in general, Myrbetriq is a more expensive, newer drug. Side effects wise, I have noticed that I have patients, for some reason, it's usually the older folks, who experience a severe dry mouth from using Versicare or oxybutynin, which is the other typical anticholinergic, and that's expected. Cholinergic is a receptor. Your cholinergic receptor is all over your body. It controls how much secretion you produce. It controls the secretions in your mouth. It controls the secretion in your eyes. It controls the secretion in your gut. But at the same time, it also controls the mechanical action of your bladder. So when you block that action, you're having all these side effects like dry eyes, dry mouth, and constipation, as well as an underactive bladder, which is a trade-off. To some people, you're taking away one problem and creating another. They get constipated. But some, they say that the dry mouth is so unbearable, they drink more fluid and they get more incontinence. So are they safe? Yes. Are they unpleasant? In some patients, yes. Do I recommend them for someone who has debilitating urinary incontinence? Yes. But then it's a question of, are you able to tolerate the side effects for the benefit? And that you will only know once you try the pill. Obviously, we can make dose adjustments. We can switch you to a different class of medications like Myrbetriq, which doesn't have the dry mouth, but it's usually more costly. It's usually a very individualized approach, and I would like to have a discussion before we proceed with one or the other.
All right, great. Thank you. Tracy, do you have any questions that you would like to ask?
Yes, as I was listening to you, you were talking about, just those muscles that are in the pelvic floor, and, the surgeries that go along, whether it's a hysterectomy or prostate surgery for men. Is it a urologist that does those kinds of surgeries? I imagine you want somebody who's good at dealing with those muscles when they remove that.
Sure. It depends on what the primary issue is. So a hysterectomy requires a gynecologist. No urologist would do it. And there are multiple reasons for a hysterectomy. You've got a benign hysterectomy where a lady has excessive menstrual bleeding, or she has endometriosis. That's a benign reason. Then you have cancerous reasons, endometrial cancer. That's a radical hysterectomy where they remove the tubes, the ovaries, everything. I won't comment too much. I'm not a gynecologist, but that's the gist of it. I would say most gynecologists the hysterectomy is their equivalent of the urologist's prostatectomy. Any urologist would be able to do a prostatectomy. Now then, within that realm is, do you have an expert prostatectomy urologist, or do you have a general urologist who does prostatectomies? Most situations, you should be expecting that a good board-certified urologist should be able to do a prostatectomy unless they felt uncomfortable doing it, and that's completely at their discretion. As far as the procedure itself, yes, you do want an expert doing that, and the individualized approach would be hysterectomy for a female, would be gynecology, a prostatectomy by a urologist. Preferably, you want to go to a high-volume surgeon. That's what I would say. Go to someone who is a high-volume surgeon, because as a surgeon, I feel comfortable referring my patients to a high-volume surgeon. So as a patient, I think everyone should be looking for that too.
Okay, we did have another question come in from a viewer out there. This one is asking, does microscopic hematuria sometimes disappear on its own? I'm not sure what that is, but if you want to describe what that is.
Sure, yeah. Microscopic hematuria is basically blood in the urine that's invisible to the naked eye. You don't see it, but every time they check your urine, they find it. It is, in theory, microscopic hematuria can be an early sign of bladder cancer. And that's primarily why urologists get involved, because you want to check. Now, microscopic hematuria there are criteria for it. It's, do you have 3 red cells under the microscope, or do you have less? If you have less than 3 red cells, there is no intervention required, no investigation required. If you have more than 3 red cells, you should have an investigation. I would support that further by saying if you're a smoker, I would have a lower threshold to investigate microscopic hematuria for bladder cancer. Does it disappear by itself? It's hard for me to say, because usually 1 is enough for me to investigate. I never let anyone leave my office and say, let's see if it disappears. If there is a urinary tract infection at the same time, you can say it's microscopic hematuria due to a UTI. We can probably recheck your urine. If there is solitary microscopic hematuria without a urinary tract infection, it's valid grounds to proceed and investigate and not hope that it goes away, because you could be delaying a potentially serious diagnosis. Infrequent, but potentially serious.
I know, speaking of UTI, I know you said so many people come in and they're not treated for it. Why do you suppose that is? Do they not know it? I feel like when I have one, I know it, but.
Yeah, it's true. I find that it's sometimes the obvious things don't seem to ring a bell. And sometimes I've noticed, especially, again, it's the elderly ladies who just, they're puzzled. Why am I leaking urine? It stings a little bit. It feels uncomfortable down there. It's not a very pronounced symptomatology where they say, oh yeah, I've got the stinging, I've got the pain, and I just feel miserable all the time. I'm peeing razor blades. That's the classic UTI. But some people don't display that. And I don't know why that is.
Great. Awesome answers. This has been a phenomenal topic, and you've done great work, and I encourage anybody that is having problems to definitely reach out to their primary care physician and hopefully get the right answer directed in the right way. I guess my last question for you is, how do people get to you? And if they're having severe problems and would like to seek more care?
So in special circumstances, we do take self-referrals, but ideally your primary should contact the SIH urology group, either Heron Medical Arts, where I am, or Memorial Hospital, Carbondale, and they will set you up with an appointment. Usually the wait time is about 3 to 4 weeks, unless it's urgent, like I said. And when I get to see you, I don't get bashful, because I'm going to ask some pretty invasive questions. And I do end up doing a genital exam, I do end up doing a rectal exam, and I do end up doing a pelvic exam. It's just the one time, and I need to know exactly what's going on, because if I don't do it, typically it won't get done. It's just something that I have trained to do. And then once that part is done, once we've broken the ice with a good old-fashioned pelvic exam, we can go on with a plan.
Awesome. Awesome. So definitely, we really appreciate your time and you being here with us today. And I hope you guys all have enjoyed this presentation, learned something, and have something to take away. And again, thank you again for being here. And Tracy has something for us, so I will pass it to her and let her give you some last minute things.
Yes, just a last minute thing. I again appreciate you, Dr. Rawal, being here and doing it in this unconventional way. Usually we're having to eat and educate and hearing all about these fun subjects over food. So, so maybe in the future we get to this COVID thing. In the meantime, a lot of work I'm doing just happens to be about doing some shared information about rehabilitation. And a brand new thing here in the last month is that outpatient rehabilitation now has direct access. So what that means is that you don't need a referral to go to physical therapy. And I do know that they have some specialized programs for pelvic floor issues. So if you are interested in that, I even found the number for that. It's 800-597-5790. And that is if you're feeling like you would like to strengthen those muscles, you're having issues like that, you've seen a urologist like Dr. Rawal or your primary care, you could maybe make that phone call and get some help that way. So.
Thank you for having me. That's wonderful.
All right. With that, everybody, we will leave you unless you have anything to add, Dr. Rawal.
I do not. No, thank you. Thanks for having me. I'll be back soon.
Yes, and he will be back next month in December for Men's Health. So definitely tune in for that class. I'm sure it will be just as good as this one, if not better. So
I know. Ladies, get your men's to do it.
Yes. So definitely check that out. And we appreciate you guys being on here today with us. And everybody have a happy Thanksgiving. And we'll see you in December. Bye, everybody.